Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I'm with Jen Gurney. How are you doing today?
I'm doing good, Dennis. Thanks.
Oh, awesome. So just cutting to the chase. This is the first time you've been on the podcast, so would you do us a favor and do a quick introduction?
Yeah, sure. So thanks for having me. Really appreciate getting to interact with the community. My name is Jennifer Gurney. I'm an Army general surgeon, trauma surgeon, and burn surgeon, and I'm currently serving in the role of the chief of the Joint Trauma System, which I hope people have heard about. It's where the guidelines come from, and we are all about data-driven combat casualty care, saving lives with data, and improving battlefield survivability.
Well, perfect. Well, one of those specialties I'm going to lean on today because we're going to talk about plasma and burn resuscitation. So just off the top, we've been doing burn resuscitation for like a really, really long time, and with crystalloids, and everything's been fine. Why do we want to change anything?
Okay, so two things. One is that, well, you're right in that we have been doing burn resuscitation for a long time. And you're wrong with I'm not sure we've been doing it right. And, if you go back in history, if you want to know the future, look at the past, right? If you go back in history, we used to use plasma for burn resuscitation. During World War II, we used plasma for burn resuscitation. During the largest fire in the United States, the Coconut Grove fire in Boston in the 1940s, I think 502 people died during that fire. We used plasma. We used what was called the Beecher formula from Dr. H.K. Beecher, who resuscitated patients from the Coconut Grove fire. And a lot of that was learned from the experience in World War II. So the better question is, why did we stop using plasma? And the reason that we stopped using plasma is because we used to use pooled plasma. So it was drawn from multiple donors, pooled in these huge vats. And so if, there was 1,000 people and one of them had hepatitis, the entire vat had hepatitis. And so yellow jaundice or getting hepatitis was not terribly uncommon. So plasma went away. What also was going on, so now fast forward from World War II to the 1970s, lots of research was being done, mostly on animals, talking about resuscitation of the interstitial space. Around the same time, we developed the technology to separate whole blood into components. And so, we always were able to take plasma off, but in terms of like platelets and cryo and RBCs. And so we just moved everything from trauma resuscitation to burn resuscitation, moved away from blood components or whole blood for trauma and plasma for burns, and we used a ton of crystalloid. The conflicts in Iraq and Afghanistan showed us very quickly that the importance of using whole blood, resuscitating what you bleed, right? And so we really evolved with our resuscitation, not just to initially a balanced resuscitation of 1:1:1, but then we evolved to using whole blood. So I think the better question is, why haven't we really embraced going back to the future and using plasma? If you look at, so with that precedent of when someone loses blood, whole blood, we replace it with whole blood. Lots of articles say that burn shock is a plasma deficit. So if burn shock's a plasma deficit, why don't we replace it with plasma? And there's really two ways that you can get plasma. One is you give it, and the other one is your liver is what makes plasma. So enteral resuscitation, which I hope is another topic for the future, and not in massive burns, but in moderate-sized burns, enteral resuscitation, where fluid is absorbed from the GI tract, goes through the liver, and you make plasma. So you can either give plasma or make plasma. So I think the question is, why did we move away from plasma, and why aren't we just really embracing it? Some centers are. A lot of burn centers have gone back to the future and are using plasma. I think the military has a huge opportunity, especially with dried plasma, both freeze-dried and spray-dried, coming back Back to the Future, we used to use dried plasma. So, we have an opportunity to start looking at how we resuscitate burn patients. I was a general surgeon and a trauma surgeon long before I did my burn fellowship. And one thing that just hit me, like, when I'd walk through the burn center, and I had a chance to train at the U.S. Army Institute of Surgical Research Burn Center, known to be one of the best burn centers in the world. We walk in the burn center and the patients look like trauma patients from 2002 and 2003, like massively edematous. Everything is edematous. Their burn wounds are edematous, their airways are edematous, their organs are edematous. And so, and that's from crystalloid. I think that this is a crystalloid injury. This is my opinion. Not everybody agrees with me. Eventually they will, maybe. But I think that this is like, we're hurting patients by giving them a ton of crystalloid. If plasma is burn shock, then the question we should be saying is, why aren't we giving plasma? How much plasma should we give? And how do you continue to monitor that? And I think we need to really start moving away from drowning patients with crystalloid. We spend the first, 24 hours resuscitating a burn patient with tons of crystalloid. And then we spend days, sometimes weeks, getting that fluid off of them, either through diuresis or CRRT. And I think that it causes not just, bad end organ issues, but I think it converts your burn wounds too. Your interstitial space becomes so much more edematous. This is like what we do to burn patients, so much more edematous. And if you have a tissue that's threatened, those capillaries, they're getting stretched out. Those red cells are having a hard time getting to the end organ. Skin is an end organ. And so I think that our over resuscitation and using a crystalloid-based resuscitation also puts burn wounds at risk for being converted from partial thickness to full thickness. That happens and you have to excise more. They bleed more. So we create this cycle from this resuscitation injury by using a lot of crystalloid. That was a long answer to your question. Why don't we use, why are we looking at plasma instead of, just still using crystalloid? I just want to emphasize we used to use plasma. So this is, so many things in medicine, we go back, especially with resuscitation science, we have gone back to the future.
One, we figured out, hey, this could be dangerous. So we just, instead of making it safe, we just avoided it. And now you give them water. And then we figure out, hey, giving them too much water is dangerous. What else can we use? So we make water more technical by putting boiled up starches in it, which turned out not to be great either. And then eventually we start going back, like the pendulum just swings back and forth, and hopefully we kind of slow it down in each direction to find out what works. But I think it's one thing to say, well, plasma is safe now, but is it measurably better? Like, I'm giving fluids not just for blood pressure, right? I'm trying to restore perfusion to the tissues.
Yeah.
In crystalloid, I guess maybe technically does that. I guess there's more volume in it anyway. What else am I gaining by giving plasma specifically?
Well, overall, so it's more physiologic. So a couple things. So remember when you give crystalloid, the formula that we're always taught, or that I was taught as a surgical resident, is that 1/3 of that stays intravascular and 2/3 of it goes into the interstitial space. What we want to give if we give colloid, and so a question to ask is why not albumin? But if you give colloid, it's going to stay intravascular. So overall, you're going to likely give less fluid and have less of the consequences of over-resuscitation. But here's the other thing about plasma. All those proteins, all those immunoglobulins, all that stuff in there, it's actually anti-inflammatory. There are some pro-inflammatory, aspects of plasma, but if you add it all up, it's more anti-inflammatory than pro-inflammatory. So it's anti-inflammatory. It restores the endothelium. One of the problems with shock is this endotheliopathy, which crystalloid makes worse and plasma makes better. So not only are you restoring intravascular volume, but you are treating the endotheliopathy of burns, and all the proteins and immunoglobulins and all this other function of plasma is supporting the resuscitation. We're going to learn a lot in the future with with more precision medicine, because people have certain coagulopathies, deficiencies. And so if you're like AT3 deficient, antithrombin 3 deficient, and you get antithrombin 3 deficient plasma, there's a risk you could get hypercoagulable. We don't test for those things. So there is a lot that we still need to learn. But going back to just the precedent, if burn shock is a plasma deficit, then restore plasma volume. The two ways to do that are the body makes plasma, or you give the body plasma. And then the less volume is also very appealing, because you don't get all the bad clinical consequences of over-resuscitation. Over-resuscitation. So when you're looking at resuscitation of a burn patient, over-resuscitation is bad and under-resuscitation is bad. We have experience in combat casualties going back to early in the conflicts in Iraq and Afghanistan, that along our continuum of care, and something I say a lot, and I think is important to remember, that, at a level 1 trauma center, it's an elevator ride. It's an elevator ride to go from the trauma bay to the, OR to the ICU. Some of this down the hall, but it's all within the same thing. In our system of care, it can be 2 helicopter rides, a fixed wing transport before you get to a specialist. And when we went and reviewed records, and this was why one of the burn CPG was one of our very first CPGs, at each level of care between like roll 1, roll 2, roll 2, roll 3, CCAT transfer, and then to launch stool, our casualties got increasing levels of crystalloid. This was detrimental. I mean, just absolutely detrimental. So under resuscitation is bad because you continue with a shock state. Over resuscitation, in my opinion, is worse, because not only can you hurt them like in the short term, but long term, all the sequelae of over resuscitation and all the edema and risk of infection, followed by sepsis, followed by prolonged mechanical ventilation. It's all, it all can be tied to some of the risks of over resuscitation.
So I just did a podcast with Dr. Holcomb on using plasma and TBI, and it sounds very similar as far as healing the glycocalyx, healing the endothelium, and hopefully not getting the edema that you would normally get. Why doesn't their own plasma fix that?
Well, I mean, you could say the same thing in someone who's bleeding to death. Why doesn't their own blood deliver the oxygen? You just don't have enough of it. In burn shock, when you get that kind of capillary leak, and if when you're looking at burn wounds, it can just be leaking fluid, and that fluid is similar to plasma. Now, the more crystalloid you give, the more they have that capillary leak, likely because of the endothelium, the glycocalyx, the tight junctions. We could really nerd out on science. I don't know if that's people will start falling asleep on the podcast listening to it. But, I have 10% battery left. But, I mean, so just going to what your podcast with Dr. Holcomb, TBI, burn, in the future, we're probably going to be using plasma for sepsis. Giving all this crystalloid, we see it. You might not see it initially in the ER. You might not see it in the roll 1 pre-hospital environment. You might not even see it early in the roll 2. But all this salt water, all this crystalloid, all this salt water that we give, it's hurting our patients long term. Salt water is for cooking pasta. Blood is for bleeding. Plasma is for burns.
Okay, very good. Especially since you only have a few minutes left. How much do I give? How fast? Current formulas right now, they don't add colloids until after 24 hours. It's just full steam ahead with crystalloids. Why do plasma early, and how much should I give?
Yeah, both like really good questions. So a lot of the protocols that are looking at plasma are giving it as a rescue therapy. If we've learned one thing in 20 years, it's that timing is everything. Timing of intervention, and earlier interventions are better. Timing, give antibiotics early for sepsis, give blood early for bleeding, give thrombolytics early for stroke. All those things, right? We've learned timing is everything. So if you use plasma as a rescue therapy, you've already damaged the endothelium with crystalloid. So plasma early is going to be really important. And I think the other thing is writing it down. We need to study this. There's still a lot that we don't know. How much to give? We usually give about a unit an hour for really, really large burns. But just like everything in burns, your initial formula is your starting point. Your endpoints of resuscitation are your blood pressure, your heart rate, your urine output, your mental status, your end organ perfusion, capillary refill. All those endpoints of resuscitation are still the same. If you have the ability to check lactate, great. Like clearing your lactate, which takes a little while to do. But all those endpoints of resuscitation. When you start any resuscitation for burns, this is why you've got to write stuff down every hour. When you start resuscitation, that's just your starting point. Then you follow the clinical parameters for endpoints of resuscitation to determine how much to give. In the Beecher days, they would use plasma and normal saline. I can't really find from the literature, and I've talked to other people. I don't really know from literature why they did both. I don't know if it's because of the way the plasma was formulated but I think you can just give plasma and follow endpoints of resuscitation. If you can check hematocrit, patients who have really bad burns, they get hemoconcentrated. Again, burn shock is a plasma deficit. So if you lose plasma, your hematocrit, which is a percentage of red blood cells, will go up. So your getting less hemoconcentrated, if you can check labs, is also a good endpoint for your plasma resuscitation. But the main ones I would go off on: blood pressure, heart rate, urine output, mental status, perfusion, I think are good endpoints. And then starting, around 300 cc's, close to a unit an hour, and then monitoring, your endpoint. If the casualty patient's awake and they're able to also do enteral resuscitation with the WHO formula, you don't want to just give them water. They will get hyponatremic. But in our CPG, the PFC CPG and the burn CPG, it says how to make enteral resuscitation. Has some bicarb, some sugar. Gatorade will also make you hyponatremic, so it needs to have more sugar, a little more bicarb. Then you can do both plasma and enteral resuscitation. I think this is going to be the future. And when I do this in the burn center, I started doing it years ago. The nurses would say to me, "Oh, it's just because you want to do things and look for prolonged care in the pre-hospital environment." No, I think this is what's better for patients. This is better than drowning our patients with crystalloid.
Yeah. I mean, just from my experience working at JC Burn Center here at UNC, they have, invasive monitoring that tells them all the numbers, right now. And I can't tell you how many times somebody will look at their heart rate, which seems to be always fast. Their blood pressure always seems to be soft. They're so bandaged up, you can't really tell a cap refill. They're either bandaged or burnt or covered with something. Rarely they look at urine output, but they're not, it's there, right? Everybody's looking at the monitor that tells them the data right now. And I think it's the human thing to just say, well, their blood pressure is a little low, their heart rate's a little high. Just give them another liter.
What we always do. We massively over-resuscitate. But you're right. That's the challenge with, not having invasive monitoring. So in the prolonged care, or field environment, not having those monitors to be able to really look at heart rate variability, and look at other ways of intravascular volume status. Burn resuscitation is hard. That's for sure. But in really, so, managing a really severely burned patient in the prolonged casualty care field environment is going to be a big challenge. I think that less is more. Keeping them warm. That is so important. They get cold really quickly with large burns. Keeping them warm. If they don't need to be intubated, then, controlling their pain, but doing some enteral resuscitation, reconstituting dried plasma and giving dried plasma, minimizing crystalloid use, and then, obviously cleaning the burn wounds as much as you can. Good dressings. I like honey. I really think honey is underutilized. It's sticky, it's pain, but nothing grows in honey, and it's good for burn wounds. And then getting them to the next level of care. If you have Silverlon, that's good. If you have Silvadene, that's good. But the main thing is keeping the burn wounds clean, and then doing resuscitation and following, urine output if you can. Which, if you're doing a big resuscitation, you have to follow urine output. Like, you have to have a Foley in them. And then, here's the other thing about burn patients. They're always tachycardic. Always. Like, if they're not tachycardic, there's something else wrong. They've got, they're always tachycardic, not massively, not to like 150s, but to 120s, 110s, 120s. That's pretty normal for a burn patient, even if you have decent pain control. And so, just they require that level of watch. And you know what? This is hard. Even in burn ICUs, you'll be standing at the bedside kind of watching how they're responding to resuscitation. I don't think we have all the answers, but I think we're getting closer by stepping away from salt water, stepping away from crystalloids, and focusing on plasma, and hopefully learning more about enteral resuscitation in the future as well.
Yeah, I think the last podcast we talked about this with Alex Merkel. It was 227. We went over a research paper about burn resuscitation, and they were adding early plasma to it. Mm-hmm. The title sounded really good. The outcomes were obvious. If you give them less fluid, the patient receives less fluid. So that was nice. But I think it's super important. And it makes absolute sense. They're losing plasma. It's probably the best fluid for them. One last question. We don't get lots of plasma, but I can get blood. Can I give blood to my just burnt patient? No trauma, no bleeding. He's burnt.
Probably not. Probably not, because they're already very hemoconcentrated. So the risk of hyperviscosity would be high. So I don't think so. I think we have to really push to get dried plasma. And there's, 4 different companies working on it. Regulatory science is not keeping up with clinical science. The FDA needs to, move on this. We do have some plasma that's being produced, ASBP starting to field dried plasma. So I think we're getting close. But no, I would not recommend giving whole blood, even though I love whole blood for bleeding. But in burn patients, since they're already hemoconcentrated, there is a risk of hyperviscosity. And that has some pretty bad clinical consequences as well.
Okay. Awesome. Since you only got a couple more minutes,
well, it's
if there was anything,
shut down.
Yeah.
Battery. I don't have my charger with me.
Yeah, we might have to record another one. But if there was any last minute thoughts as far as convincing somebody who has plasma to give plasma, what would you say?
Yeah, walk into a burn center, look at a patient that's being resuscitated with salt water, and look at a patient that's being resuscitated with plasma, and you'll decide pretty quickly which one's looking better. I mean, burn injury and thermal injury is a horrible, horrible traumatic injury. These patients do suffer, and anything that we can do early in their resuscitation to improve their outcome, decrease the amount of potential burn wound excision that they need, decrease their risk of infection, control their inflammation. All those things will benefit, our burn patients. The pre-hospital environment is always harder than the ICU environment. And plasma is just going to be much more feasible. Also, it's going to be less weight in cube, if you think about it, for medics to carry, freeze-dried plasma, smaller pouches, and a liter of crystalloid. So I think that there are so many clinical and operational benefits. And, the lack of massive over-resuscitation means less casualties will need to be intubated. And so there's just so many clinical, operational, logistical benefits to resuscitating with plasma. And going back to the papers from almost 100 years ago, if burn shock is a deficit of plasma, then giving them plasma is giving them what they need. Just like after traumatic injury, a hemorrhage, or losing blood is a deficit of whole blood. Don't give crystalloid, don't give component therapy, give whole blood. I mean, this is bringing some common sense back into, medicine. Not to say that we lost it, but sometimes we move a little bit away from it.
Yeah, I think so. Well, awesome. I really appreciate you jumping on.
Yeah, thanks, Dennis. And I'm sorry that I don't have my charger and my phone's about to go flat, but if maybe I'll have a chance to talk to you again. Appreciate all your for prolonged field care, prolonged casualty care.
All right, thank you very much.
Take care.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast, out.